This is Teresa McLean, and today's lecture will be care of the patient with dysrhythmias. We've already talked about many different dysrhythmias, so now we're going to talk about how to take care of patients who have them, what kind of medications to use, and what other things are available to us. So let's begin. When we talk about caring for a patient with dysrhythmias, probably one of the first things that comes to mind is taking care of patients through the use of medications, or what we commonly call anti-dysrhythmics or anti-arrhythmic type drugs. These types of medications act by altering electrophysiologic properties of the heart. They act either by blocking flow through ion channels or by altering autonomic activity. The ions responsible usually for this activity are sodium and calcium, found outside of the cell, and potassium, found inside the cell. If you remember, depolarization occurs when sodium and calcium rush into the cells. So one thing to keep in mind is that antiarrhythmics can also produce new arrhythmias. So, while these drugs are good, they are also called pro-arrhythmics, meaning they can make other arrhythmias occur. So let's talk about the four major classes of anti-arrhythmics. The first class are Class 1 sodium channel blockers. These drugs block sodium to help prevent depolarization. They slow the impulse conduction through the atria and the ventricles. And they are used to treat life-threatening ventricular dysrhythmias. Sodium channel blockers are put into three subgroups. They are Class 1A, 1B, and 1C. Class 1A blocks fast sodium channels and prolongs the action potential duration. They are said to have moderate effects. The two major drugs in this class are pronestal and quinidine. They also are said to have very narrow therapeutic windows, meaning that levels below a certain point and above a certain point are not very good. For pronestal, the therapeutic window is from 4 to 10 micrograms per milliliter. Quinidine's therapeutic window is from 2 to 5 micrograms per milliliter. Both of these drugs may be given IM, IV, or PO. Not used a whole lot, but occasionally you will see them. They're fairly older drugs. Class 1B are said to have little or no effect on slow heart rates, but have an effect on fast heart rates. They are said to be the least effective of the sodium channel blocker group. They shorten repolarization. The three drugs in this group are lidocaine, mexiletine, and dilantin. Off the top of your head, you can look at dilantin and see that, that's strange. This drug is an anti-epileptic drug. But it can also be given for digoxin-induced arrhythmias. Lidocaine is a very old drug. It's considered the weakest in the class and is given IV only for VTAC and symptomatic PVCs. It was the drug of choice many years ago for treating these things, but now we've moved on. However, some cases you will see lidocaine given. The therapeutic window for lidocaine is 1.5 to 5 micrograms per milliliter. If by chance someone has a lidocaine level greater than 5 and gets toxic, the first bad side effects you will see are seizures. Mexiletine is the orally active lidocaine dose. So, lidocaine's only given IV. but if need be, you can give mexilatine. And as I said, these drugs are very old. And if you think about lidocaine, remember that lidocaine is given a lot of times in dental offices, and it's given to deaden an area before work is done. In much the same way, that was the way lidocaine, or it still is the way lidocaine acts in the heart. It deadens an area. So when it's given IV, in order, it's based on weight. So when patients become or are said to be at a point where they can be weaned off of lidocaine, generally what happens is the drug is just should be weaned down, but sometimes can just be turned off because we say lidocaine is self-weaning. You turn the medication off and it gets out of your system, so the half-life is very short. However, as I did say, it is very easy to get toxic on lidocaine, and toxicity will lead to seizures. The class 1C group of the sodium channel blockers gives the strong sodium channel effect. It shows no effect on repolarization, and it does prolong the action potential. The two drugs in this category are Tambacor, also known as flecainide, and Rhythmol, also known as propofenone. Tambacor has a very narrow therapeutic window, ranging from 0.2 to 1 microgram per milliliter. Anything greater than 1 is considered toxic. Rhythmol is usually given for strong life-threatening SVT or VTAC. Nursing considerations for Class 1 sodium channel blockers include maintaining a baseline EKG, electrolytes, renal, and liver function test, monitoring for changes in level of consciousness and respiratory status, monitoring for diarrhea and lupus type effect if on quinidine and pronestal. Primarily we see diarrhea when taking quinidine, and the lupus type effect, which includes the butterfly rash and problems within the joints. People will complain of joint pain or stiffness when on pronestal. Patients should be avoiding alcohol, caffeine, and tobacco, and citrus, especially when they're on quinidine. We need to make sure we monitor for therapeutic windows, making sure that people do not get toxic. We also need to make sure that we check to see what other drugs patients are on when they're on these sodium channel blockers. Drugs such as digoxin, cimetidine, also known as Tagamet, not used much, nifedipine, also known as Procardia, warfarin, and other anticonvulsants, as they can cause a dangerous interaction and potentiate lethal arrhythmias. This class, sodium channel blockers, is also considered very pro-arrhythmic. Class 2 types of antidysrhythmics are the beta-adrenergic blockers, and everyone has heard of these. In fact, you've probably given them, mainly for hypertension, but they're also considered antidysrhythmics. They block stimulating effects of adrenaline on the heart. They slow the heart rate and decrease the conduction velocity through the AV node and decrease the release of renin. They block beta receptor sites in the heart and the kidneys, thereby decreasing heart rate and cardiac output. Beta-adrenergic blockers are used to treat atrial dysrhythmias, generally associated with heart failure. They can also be used to treat angina and prevent recurrent MI. You need to keep in mind that abrupt discontinuation can lead to dysrhythmias and hypertension. Two drugs in this class are Inderal, aka propranolol, and Brevibloc, also known as Esmolol. Nursing considerations for these class 2. Excuse me. Nursing considerations for Class 2 include monitoring heart rate and blood pressure, because we do know they can cause hypotension, monitoring for hypoglycemia in patients with insulin-dependent diabetes, because they may inhibit glycogenolysis. We need to make sure that patients report a pulse less than 50 and to caution them about changing their position slowly. Class 3 are your potassium channel blockers. They block potassium ion channels in myocardial cells. They prolong the refractory period, delaying repolarization. They're usually prescribed in addition to internal cardiac defibrillators in patients with high-risk sudden cardiac death. Examples of drugs in this category are cortisone, beta-pace, Ticacin, Stedacor, and Multac. Cortisone is usually used for unstable VTach or can be used for supraventricular tachycardia or people who have impaired cardiac function. Beta-pace is in the chemical class of beta blockers, but is in the functional class of Class 3 potassium channel blockers. Ticacin you'll hear of used for the conversion and maintenance of highly symptomatic atrial fib, atrial flutter. So patients that have uncontrolled heart rates in atrial fib or flutter generally will be placed on Ticacin when other things fail to help convert them into sinus rhythm and maintain them into that sinus rhythm. Stedacor, or azimolide, has a half-life of 4 days. It works well on all types of heart rates and is given in tablet form. Multac, or dronedarone, has a half-life of 24 hours. It's known to block multiple channels and cells involved in cardiac conduction. You need to keep in mind that blood concentration increases with food. It also comes in tablet form. Nursing considerations for this class of potassium channel blockers includes prolonging the QT and can cause torsades. Amiodarone side effects include different neurologic sequelae, which could end up being with stroke or just some different headaches, nausea, shooting pains, as well as pulmonary fibrosis, thyroid abnormalities, and skin discolorations. Beta-pace can also cause pulmonary fibrosis. Stedacor is one drug that they found that has a decreased effect to the lungs and the thyroid. Side effects on this drug include headache, dyspnea, fatigue, nausea, diarrhea, and dizziness. Dronedarone has a few different side effects. Those side effects include shortness of breath, wheezing, rapid 5-pound weight gain, feet and ankle edema, and chest tightness. Other things to keep in mind when taking potassium channel blockers are to make sure that patients wear sunscreen and get regular eye exams. They should take these drugs with food or a small snack, and report any skipped beats, cough, vision changes, jaundice, and right upper abdominal pain. Class 4 calcium channel blockers block calcium ion channels in the heart, which reduce the automaticity in the SA node and slow impulse across the AV node. This results in decreasing the rate and conduction, as well as decreasing oxygen demand, cardiac workload, and increasing oxygen in the myocardium, which is a good thing. They can stabilize certain dysrhythmias, but also cause lethal ventricular dysrhythmias. Two examples are cardizem, also known as diltiazem, and verapamil, also known as isopten. Both can be used IV. Nursing considerations for calcium channel blockers include changing positions slowly, especially in the elderly, since this drug can produce peripheral arteriolar vasodilation. We want to make sure patients know to report blood pressure changes and a heart rate less than 60. The other two very common side effects that happen are constipation and peripheral edema. These are big side effects to let patients know about because these are the two side effects that will make patients go off these drugs quicker than anything. For most women, no one wants to walk around with a full belly and any cankles. So we always tell people this is a side effect, but it can be overcome if you just give it a little while. And plus, we can tell others what to do, like increase their fiber, increase their water, put their legs up, get a little more exercise. Finally, the last class of antidysrhythmics is a miscellaneous class. In this class are several drugs. Probably the biggest drug in this class is an endogenous nucleoside called adenocard, also known as adenosine. It's used for the treatment of serious atrial tachycardias by slowing conduction through the AV node, which prolongs the refractory period and decreases the automaticity of the SA node. It has a half-life of about 10 to 15 seconds. When we give adenosine, we are said to be doing a chemical cardioversion. So instead of using a machine, we are actually using a drug to cardiovert people out of these rapid atrial tachycardias. When giving adenosine, it is usually given in bolus doses, about 6 milligrams times 2 doses. It must be pushed into IV access quickly to be successful. Just like when you're giving or you're defibrillating or cardioverting with a machine, you punch the button quickly. It sends a shock quickly into the system. With adenosine, you're pushing it in as quick as you can give it, with IV fluids hanging quickly behind it, therefore rushing into the system and preventing any conduction. So if you're looking on a monitor, what you're going to see is this rapid atrial tachycardia with adenosine hitting it very hard. And once it hits it and gets into the system, it will hit the SA node with such force, then the next thing you're going to see is a straight line. So you should see an isoelectric line once the drug gets into the system. Sometimes it takes 2 doses before it will actually work. The hope is that once the patient straight lines, or you see the isoelectric line, the next thing you're going to see is a resetting of the heart rate and rhythm. So the hope is that patients convert to a sinus rhythm. 2 other drugs in the miscellaneous class are magnesium sulfate, usually given for effective treatment of ventricular tachycardias. It is known when we give magnesium, we usually are helping to increase the potassium level in the cells, thereby helping maintain potassium levels. Digoxin is a very old drug. It is an endogenous nucleoside, so it's one of those that's been given over and over, and for sure you've probably given it multiple times. It's still around. I'm going to let you go and review that one on your own. Nursing diagnoses for all patients with dysrhythmias include ineffective tissue perfusion, cardiac, related to cardiac conduction abnormality, and risk for decreased cardiac output, related to inability of the heart to pump effectively, secondary to dysrhythmia. Let me repeat those. Ineffective tissue perfusion, cardiac, related to cardiac conduction abnormality, and risk for decreased cardiac output related to inability of the heart to pump effectively secondary to dysrhythmia. For patients that have dysrhythmias, a lot of times when physicians want to know how to best treat these dysrhythmias, they will conduct an EPS study or an electrophysiologic study. It is a procedure done by cardiac cath or coronary angiography. It is used to detect arrhythmias and their origin. It actually can reproduce that arrhythmia in the lab. It can also be used to analyze components of the electrical system to really look at the conduction pathway. It can be used to identify sites of ectopic stimulation. So once a site is established, they can use ablation to treat rapid heartbeats that begin in the atria. So things such as supraventricular tachycardias like atrial fib, atrial flutter, or other atrial tachycardias. And finally, they can be used to evaluate the effectiveness of treatment. So it determines how patients are doing on their medication regimens. Things to think about is if you had a patient return from the cath lab after this procedure, what would be some of your nursing responsibilities? Think about that for a minute and be ready to answer that question when we meet in class. Shock therapies are also ways to treat dysrhythmias. Shock therapies include cardioversion, defibrillation, and chemical cardioversion. Cardioversion is elective. It is what we call repolarization under sedation, and it is used to treat SVT, supraventricular tachycardia, rapid atrial fib, atrial flutter, and hemodynamically stable ventricular tachycardia. Generally, when we cardiovert someone, we set the cardioversion with the patient's own rhythm, and shocks are usually given in sync with the R wave. After cardioversion, we must make sure that we assess the airway, the oxygen level, vital signs and level of consciousness. Make sure that we put them on any antidysrhythmics that the physician may order. We want to assess the patient's skin. We want to give them emotional support and document. We know that patients with atrial fib are at high risk for thromboemboli, especially post-cardioversion. So there's a lot of things we need to monitor for. Defibrillation is different than cardioversion. Defibrillation is non-elective. It is considered an emergency situation. We don't have the ability to wait around and see how the patient is doing. We must use electricity and emergently defibrillate them. The chemical cardioversion I've already talked about, and if you remember, the drug's name is adenosine or adenocard. Please remember the nursing considerations for each of these. We've talked about treatment for people with fast heart rates. Now let's talk about treatment for people with slow heart rates. Two drugs to keep in mind. The first one is atropine. It is in the class of anticholinergic drugs and is used when the heart rate is less than 60, usually in the 40s, and the patient is symptomatic with an undetermined cause. What do we know about atropine? Is it usually blocks vagal stimulation. Dosage is 0.5 milligrams every 3 to 5 minutes to a maximum of 3 milligrams. Generally, if we know that a certain drug is the culprit, then we remove or hold the drug and let the rhythm return to normal. In cases where the rhythm will not return to normal very quickly, atropine can be used. So remember, it is an anticholinergic, so it will increase the heart rate. But the side effects go with it are dry mouth and urinary retention. We do know that atropine is not effective in second-degree heart block type 2 or complete heart block. It can also cause chest pain by speeding up the heart too fast. So while it is a good drug, it doesn't come without some side effects that are aggravating. Epinephrine is generally what we call a code drug. It is a sympathomimetic. It's used to stimulate the heart to increase both heart rate and contractility. It's usually given after the second rhythm check following ventricular defibrillation or ventricular fibrillation, and either immediately before or after the second defibrillation. It can be given every 3 to 5 minutes. Pacemakers can also be used for the treatment of slow heart rates. They are in the classes of temporary and permanent. In general, all pacemakers have two components, an electronic pulse generator and pacemaker electrodes. The generator determines the rate, the strength or output of electrical impulse going to the heart. So first, let's talk about temporary pacemakers. Temporary pacemakers are used for short periods of time. They are usually used for conditions that cause severe bradycardia that compromise cardiac output. So conditions such as digitoxicity, post-op coronary artery bypass patients, or valve replacement patients. There are two types of pacemakers that are temporary, and those are in the categories of non-invasive and invasive. Non-invasive is an external type of pacemaker that goes by the trade name of Zoll. So, what is it you need to know about a Zoll pacemaker? Zoll pacemakers are used on the skin, and there's two big patches. You have a patch that goes in the front, which is the negative electrode, and it is placed halfway between the xiphoid process and the left nipple. And then one patch goes in the back, which is the positive electrode, placed beneath the left scapula and left of the spine. With Zoll pacemakers, you set a pacing rate and a stimulus threshold. The stimulus threshold is the lowest amount of current to achieve capture, meaning the lowest amount of current that will help you to see a pacemaker spike with a cardiac contraction right afterward. And so that is called capture. Presence of an adequate pulse and blood pressure shows that you have mechanical capture. Complications of the Zoll pacemaker include skin and muscle discomfort, loss of capture, and inappropriate pacing. So if you can imagine, you have a patch on the front and a patch on your back. And so what these patches do is they actually press inward, one from the front, one from the back. So it causes a lot of muscle weakness over a period of time, especially if you have to use a lot of energy to make those contractions appear. The other thing is a lot of people are very sensitive to the adhesive in the patches, so they tend to get a lot of skin breakdown from that, so you have to monitor. With like anything else, if you're going to use them externally, there's always going to be that chance of not being able to see that contraction or not being able to get a good contraction out of it. So they're not the best in the world, but sometimes it's just an easy fix until the rhythm starts to correct itself or a drug starts to get out of your system. The invasive type of temporary pacemaker, there's two different kinds. You can have an endocardial pacing wires, or you can have an epicardial pacing wires. These wires are usually connected to an external pulse generator. Endocardial pacing wires are usually placed either through subclavian, jugular, or femoral veins into the right ventricle. Epicardial pacing wires are electrodes that are directly placed on the surface of the heart, and these are the ones that you will see placed right after open heart surgery or valve replacement surgery. And generally when you're taking care of those patients, you'll notice that they have little wires that are hanging out the front or the anterior part of the chest. Complications from temporary pacemakers invasively are infection at the insertion site. You can also get premature ventricular contractions or beats. They're also known to have loss of capture, as well as you can get some electromagnetic interference. It doesn't happen as much anymore, but occasionally you'll see that. Permanent pacemakers are used in conditions that place permanent damage to the conduction pathway, such as a massive MI or valvular surgeries. Occasionally people will undergo a valvular surgery where they've had to go through so much of the conduction pathway that it doesn't quickly regenerate itself, or it will never regenerate itself. Pacemakers are usually implanted underneath the clavicle on the left hand side, so right underneath the clavicle. They're very small these days, which is very nice for most. All pacemakers have international codes, which consist of 3 letters, each representing a facet of the pacemaker's function. There are actually now 5 codes for pacemakers due to the internal cardiac defibrillators. But what I want you to remember are the 3 major pacemaker codes. So, when you're looking at the pacemaker codes, you may see 5 letters, but the first 3 letters are going to be very important to you. The first letter means the chamber that is paced in the heart. If you see an A, stands for atrium, a V stands for ventricle, or a D stands for dual, both atrial and ventricularly paced. The second letter stands for the chamber that is sensed. Once again, A equals atrium, V equals ventricle, and D equals dual, atrial and ventricularly. Occasionally you will see a O for none, meaning that neither, no chamber, atrial or ventricular, is sensed. And the third letter is the action or response to a sensed event or signal. The letters used in this category are I for inhibited, T for triggered, D for inhibited and triggered, and O for none. Now let's talk about principles of pacemakers. The number of times a pacemaker will fire is determined by the sensitivity setting of the pacemaker. Let me repeat that. The number of times a pacemaker will fire is determined by the sensitivity setting of the pacemaker. Low sensitivity means the pacemaker ignores the patient's ventricles and paces more frequently. Low sensitivity means the pacemaker ignores the patient's own ventricles and paces more frequently. A high sensitivity means the patient's ventricles will be allowed to discharge. So, two problems that can happen with pacemakers are failure to sense and failure to capture. With failure to sense, the pulse generator does not sense the patient's own rhythm and does not inhibit itself from firing. This can be very dangerous as it can hit during the vulnerable period, causing either VTAC or VFib. Let me repeat that. Failure to sense is when the pulse generator does not sense the patient's own rhythm and does not inhibit itself from firing. So, it's very dangerous and it can hit during the vulnerable period, causing either VTAC or VFib. Most commonly, we see it causing VFib. Failure to capture is when the pacemaker initiates an impulse, but the stimulus does not produce depolarization. The pacemaker initiates an impulse, but the stimulus does not produce depolarization. In other words, you'll see a pacemaker spike, but no ventricular electricity afterwards. So that pacemaker has failed to capture any ventricular activity. When this happens, we want to make sure that we check our connections. We want to check our batteries, because sometimes battery failure is one of the problems in permanent pacemakers. In other pacemakers, we want to make sure we'll change the pulse generators. We might be looking for broken or displaced wires, or it may be just that we need to reposition the patient.